I was asked to talk about the impact of donations on neonatal care, and I think it's a very appropriate subject to talk about, because we often underestimate or take for granted the amount of support that we are actually receiving from donations through families and organisations in all really facets of neonatal care. So I wanted to start by describing what neonatal care is. As neonatologists and paediatricians within a maternity hospital setting, we do a wide range of medical care, and a member in the audience was asking about babies, sick babies that are transferred to a children's hospital to get more intensive care. We in fact provide intensive care to sick preterm infants here, and most of our infants that are admitted to the Rotunda remain in the Rotunda for all their care here. So we care for preterm infants that require a huge amount of intensive care, particularly if they're born within the first, within the kind of beginning of the third trimester at 24, 25 and 26 weeks. We also care for critically ill term babies. So babies born at term can sometimes be born extremely sick and extremely unwell and require intensive care. Thankfully, we also provide care to the healthy babies that go on the postnatal floor with minor issues and advice, and healthy babies, and we provide follow-up on common neonatal issues within our paediatric outpatient department. We also provide long-term follow-up for babies that are born extremely preterm or sick-term babies that have critical illnesses at birth, to make sure that they're developing adequately, and if not, we do refer them to early interventional services when that is appropriate. We also provide oversight and on-the-ground support for transporting of sick babies either from the Rotunda out or from within the country back into the Rotunda. So as you can see, we provide a kind of wide range of medical care that ranges from intensive care to kind of less acuity. Just to give you a snapshot of our figures last year, we had over 1,300 admissions to our neonatal intensive care unit, and as you can see, unfortunately, we do have some neonatal deaths, and our discharges were 1,273. Most of our babies are over 1.5 kilos, but a significant number of babies are actually born quite small. You could see that we had 46 babies between 500 grams and 1,000 grams. That's under 2 pounds in weight. And as you can see in the first table, we also treat a lot of babies on the ward beside the mother to keep, so as much as we can, we try to keep baby and mother together for a variety of obvious reasons. So we provide a lot of medical support and care to babies on the postnatal floor. And we have a very busy outpatient department where we see over 8,000 babies annually for a variety of reasons. And as I mentioned, we're quite actively involved in neonatal transport. There were over 600 transports, and the Rotunda Hospital has conducted around a third of those. And a lot of the babies come into our unit for care from around the country. And we also sometimes transfer baby outs for more specialised care to the paediatric intensive care units. So it goes without saying that the care of premature and sick-term infants is extremely complex and challenging. And as you can see here from this picture, beside all the different high-tech equipment, the baby lies down there in the middle. We need a huge amount of equipment to provide intensive care support, pumps for administering medication, ventilators for supporting the baby's breathing. We do a lot of intensive monitoring of the brain activity of the baby, how the heart works as well. So, as you can gather, we need a lot of expensive equipment to do that, and a lot of money needs to be spent in order to provide all these expensive equipment. And unfortunately, we don't get all this money from the HSE due to the obvious financial restrictions that we're all facing at the moment. And it's a sad reality, but neonatal care is very low down on the priority of the government, unfortunately. So we don't get a lot of funding coming our way. So we do heavily rely on donations that come from families and organisations to enable us to provide optimal care. I can just briefly go through some of the equipment that we use. Sorry. So we need a lot of ventilators. We also need a lot of equipment to monitor different activities of all the different organs and body functions. So we have continuous monitoring of the heart, of the brain activity. We also need to continuously monitor the level of carbon dioxide and oxygen in the baby's blood, especially when they're being provided with intensive ventilation. We can also monitor the electrical activity of the brain and also the function of the heart using echocardiography. And we need other equipment to provide some therapeutic interventions like cooling in babies that undergo perinatal asphyxia. And these are all expensive equipment. Breast pumps as well, and we need a lot of those because we all know now that providing breast milk as early as possible to critically ill term and preterm babies significantly improves their recovery and outcome down the line as well. So, as I highlighted, we do have a lot of funding challenges. We are significantly underfunded by the HSC. The equipment is expensive, and on top of the funding restrictions, we're also facing significant staff shortages as well. And I'll just give you a comparison between our staffing numbers and staffing in other similar hospitals in different jurisdictions. On the first column here, you could see Mount Sinai Hospital in Toronto that has 8,500 deliveries compared to our nearly 9,000 deliveries per year. We admit 1,400 babies compared to their 1,700. However, they admit far more babies to the unit than we would actually handle on the postnatal floor beside the mothers. So if you combine that, we would probably have about 2,500 admissions compared to their 1,700. You could see that our bed capacity falls far below what they have. Look at the nursing staff numbers. They have 180 nurses compared to our 65, and also they have 3 times the number of advanced neonatal nurse practitioners and respiratory therapists compared to ours. And they have 15 neonatologists to our 5. So we are significantly under-resourced as well from a staffing perspective. But it's not all doom and gloom. The donations have helped us significantly over the last number of years to provide a kind of holistic approach to how we provide care to the neonatal intensive care unit. And I'm going to focus on my subspecialty, which is hemodynamic research. So really when we provide care, we don't just talk about the clinical care which you see in the blue box. Research is also very important, and teaching and training of our junior staff as well. These are all very important aspects of providing neonatal care. We can't be bystanders in the kind of ever-expanding field of research, and as you saw throughout the day, there's a lot of innovative and exciting research going on here in the Rotunda, and we don't do it for the sake of doing research. We do it to ultimately improve patient outcome, both maternal and neonatal as well. So donation money that goes on research does have the ultimate aim of also improving outcome. Training our junior trainees as well in attaining some special skills to provide specialist care for the neonatal population is also an important aspect as well. So I just want to give you an idea of the support that we have received from the hemodynamic perspective of how we care for the baby's hearts from Friends of the Rotunda over the last few years. They have funded a very exciting study, and we'll be speaking to a participant of the study after my talk, to the tune of €97,000. And that was also partly funded by the MRCG partnership. They've also purchased a state-of-the-art echocardiographic machine. This machine enables us to scan the hearts of the babies and obtain very useful information to help both in research and clinically as well. So it's an ultrasound scan of the baby's heart. And we also purchased a brand new monitor that monitors how much blood is pumped by the baby's heart continuously as well. And this technology is quite new, and up until now, we weren't able to really find out how much blood is being pumped by the heart on a continuous basis. And this has significantly improved how we do research and hopefully how we care for these babies clinically as well. Before I put on the next couple of panels, just digressing a bit, we always try and teach, we're teaching our daughter now the kind of how to handle social media. And what we say to her is, never put anything on the internet, be it a picture or a saying, that you're not prepared to hang on your front door of the house for everybody to see. And obviously the fellows that Friends of the Rotunda have also funded did not heed this advice, and I got this from Facebook. I love the handlebar mustache, particularly here. But joking aside, the donations have also helped fund neonatal research fellows to help carry out all this research that we're doing at the moment. In terms of benefits to clinical care, the equipment we purchased has really kind of transformed how we provide care, particularly from the heart perspective for babies. So in 2015, we performed over 1,000 echocardiograms, 1,000 ultrasound scans on babies in about 343 babies. And as you can see, we perform a lot of follow-up scans to look at how we're doing when we actually identify a problem on echo, start treatment, and then do another echocardiogram to follow response. We have shown significant improvements on how we manage the infant's cardiovascular system, and also we're able now to identify problems in the heart before they become clinically apparent. So this is an example of an echocardiogram. On this side here is a picture of the left ventricle, which is one of the pumping chambers in the heart, pumping in a normal way in a healthy baby. I'm sure you can appreciate that on the panel on this side, the heart is not really pumping as well as it should be when you compare it to the other panel here. And this was an echocardiogram that we actually performed last week on a baby that came from delivery critically unwell, that could have had one of 10 or 12 diagnoses. But the echocardiogram was able to quickly tell us that the main issue is the heart, and we were able to target that and demonstrate very significant improvement in the baby's clinical situation within a short period of time. The hemodynamic monitor that I spoke to you about, I think, is going to be very exciting. It's very clever technology. All it entails is applying some stickers on the baby's torso, and it's able to give us continuous readings of how the heart is working. And we're able to look at the effect of medication on the baby's well-being. I'll just focus on the red line here. The red line is the cardiac output, or how much volume the heart is pumping. This baby was getting sicker and sicker and over a 4 or 5 hour period. And as you can see, the machine was showing that the cardiac output of the baby was pretty much plummeting. And you could see that the blood pressure wasn't really changing that much. And currently, blood pressure is the only way we have to try and guess whether the heart is working fine or not. And you could see that it demonstrating a significant improvement once we started a new medication called adrenaline, and we were able to kind of reassure ourselves that this was a correct choice of medication, whereas in the past we had to guess whether the baby was getting better or not. But this was able to tell us before the baby became clinically better. In terms of clinical research, we really have kind of jumped leaps and bounds over the last 3 to 4 years. We were able to characterize heart function in preterm babies and demonstrate what is normal and what is abnormal, and we're able to use echocardiography to predict poor outcomes in babies and demonstrate poor heart function in conditions occurring, especially in twins, where previously we thought that the heart function was okay. And we're also beginning to examine function in fetuses as well. And this is an example of how we can characterize heart function. This technology is relatively new and relatively novel, and with the donations that we have received from families and organizations, we're able to purchase this equipment and do some really high-tech research into characterizing how the heart works. With the help of Professor Fionnuala Breathnach and Dr. Olaf Franklin, MFM specialist and cardiologist, we're also doing this in fetuses as well. And this is a picture of of a heart beating in a fetus, and we're able to assess the function in fetuses in a similar way as we do in babies after they are born. And we've had good results in terms of, we had over 20 peer-reviewed papers, 15 international presentations, and we have 2 ongoing RCTs, as Professor McCallion described earlier. We're also investing in purchasing some high-tech simulation equipment to teach echocardiography to new candidates. Practicing echocardiography on vulnerable preterm babies, if you don't have a basic level of skill, can actually cause some harm because they can deteriorate very quickly. So we're trying to move away from having the early phase of training at the bedside to having it on an echo simulator, and soon we'll hopefully be able to do that. And with the donations that we are receiving, we're hopefully able to purchase some state-of-the-art equipment. This machine, costing €40,000, is a new laser eye equipment machine that we can use by our ophthalmologist. This can be used by our ophthalmologist to provide some high-tech laser surgery to prevent blindness in preterm infants. And this is a serious issue that can also be addressed. We're also going to buy some laryngoscopes that have cameras in them, and that will make it easier and simpler for us to pass tubes into the baby's tracheas, especially in times where it is difficult to do so. And finally, I just want to acknowledge the Trojan work that's done by Sheila Thompson, and really acknowledge the donations that we get from all the parents and all the supporting organizations, because without you guys, we really wouldn't be able to provide the high level of care that we can. And although I only focused on the hemodynamic aspect of what we provide, these donations have really kind of spanned all the kind of parts of the care that we provide. So thank you very much for listening. And I'd like to call on Louise now to share her experience with us. I just want to welcome Louise and her baby girl Eris up on the podium here. So Louise was was a participant in our handle study. This was a study that was using the Hemodynamic Monitor that I kind of demonstrated in preterm babies on the mothers during their pregnancy to see if we can predict mothers developing preeclampsia early on. So it's a very exciting project, and we finished recruitment now. And I just want to show people a sense of what it feels like to be part of this research. So Louise, I'll start by asking you, what made you actually agree to participate in the handle study?
It was actually on my first appointment when I was 12 weeks, when I was in the department in there. Lisa actually approached me and she said I fit the criteria, so I was delighted to be actually able to partake in a research project, to be able to give something back. Even though Eris was my first baby, we will be coming back. So it was actually, we were delighted to be able to partake in the research project. Thank you.
And what was your experience like?
Very good. Obviously on that first day I had all my tests done, and then when I was due to come back in for appointments, every morning Lisa would give me a ring to see when would suit to do the research, and she basically worked it around me. So if I was in early, I'd be able to go pop up to her and get the job done and dusted, and if I was running late, then we do it afterwards. But I wasn't put out at all. It was basically, they worked around me. So.
Yes. And from your experience of a user of the services, do you think that research is important?
Oh, big time, because I've had friends who have suffered from the preeclampsia, and it's silent as well. So it was good to be able to, as I say, give something back in the form of research. Unfortunately we didn't get it, so you couldn't study us more.
Well, I mean, it's obviously fortunate that you didn't get it. So, so thank you very much for coming up, and thank you very much for your time. Thanks.